Thank you to Steve and to the organisers for the invitation to be here, and it's lovely to be back again. So I'm going to primarily talk about the MiNivAn study, which we hope will be opening soon in the UK. But in order for that to make sense, I thought I would start with a bit of an overview of what immunotherapy is and what it aims to achieve and how it contrasts with chemotherapy. And talk about the individual elements of the MiNivAn trial, which are anti-GD2 antibodies, anti-PD-1 antibodies, and MIBG therapy. And then I'll touch briefly on the end about other things that we may be able to use in combination with anti-GD2 antibodies. So the immune system is throughout our bodies, from the tonsils, the glands in our neck, spleen, the lymphatics next to the blood vessels, and the bone marrow. And it's composed of both cells of the immune system, so you see a picture there at the bottom of an immune cell, and also proteins called antibodies. And between those different types of arms of the immune system, we fight infection and recognise things that are foreign. And that's primarily bacteria, viruses, infections. But also we have the potential to recognise cancer. And the aim of the immune system is to recognise things that are foreign and then try and get rid of them from the body. And one of the key aspects of the immune system is that the immune system remembers what it's seen, so that if you see it again, if it sees it again, it can react more strongly and quickly. So the paradigm of that would be chickenpox, where you get it the first time, but then hopefully if you meet the virus again, you've got immunity and you don't get it again. The other key feature of the immune system is it's highly specific, so it's very good at measuring a specific virus and having immunity to that virus. But if you've had chickenpox, it recognises that, but not measles. It knows very subtle differences between bacteria, viruses, and the things that it sees. And the aim of immunotherapy is to use that specificity, so the ability of the immune system to recognise individual proteins on cells, bacteria, viruses, and recognise them as foreign. And almost all tumours, almost all human tumours, have some proteins on their surface that are different from normal cells of the body. Either they're completely unique and not normally found in the body at all, or they're found in greater abundance, in higher frequency than in normal cells. And those differences, these proteins on the surface of tumour cells, give the potential to use the immune system to provide a highly specific therapy for cancer. And that contrasts to chemotherapy, which relies on the fact that it targets cells that are dividing quickly, like cancer cells, and dividing relatively more frequently than normal cells of the body, but isn't very specific. So chemotherapy will target all cells in the body that are dividing and growing quickly, including the bone marrow and blood cells. So we hope it has the potential to be a highly specific therapy for cancer, and also one with very different side effects and toxicities from other standard cancer therapies. So you'll hear about monoclonal antibodies, and that just means really pure antibody that's been generated in the lab. Until the 1970s, in order to make an antibody against something for clinical use or for experiments, it had to be done using goats or sheep or horses and injecting the animal with whatever protein you wanted, and then taking all the blood and purifying it from the blood, which is obviously not a terribly practical way of getting pure antibody. And in the 1970s, the technology was developed to make unlimited amounts of very pure monoclonal antibody in the laboratory. And since then, there's been an explosion really of antibodies targeting different proteins on the surfaces of cancer with the aim of treating the cancer. And there's currently 24 antibodies that are licensed that's in the United States for the treatment of different cancers. And far more than that, over 500 antibodies that are in various different stages of development. And basically, antibodies are a kind of Y-shaped structure, Y-shaped protein, and the top bit of the Y is recognises a specific protein, and the bottom bit of it interacts with the immune system. So the idea of using antibodies to target cancer cells is that the specific bit of the antibody will recognise a specific protein on a cancer cell that's not on other cells of the body, and coat the cancer cell, and then cells of the body's own immune system, such as natural killer cells, will come in and gobble up the tumour cell that's been coated with antibody. And in the case of neuroblastoma, there's been a lot of work done looking at the molecule GD2, which is a ganglioside on the surface of virtually all neuroblastoma that's found, and using antibodies that target that to treat neuroblastoma. It's a potentially a good target for treatment because it's found on virtually all neuroblastoma tumours, and it's not found on many other tissues of the body apart from, and importantly, it is on nerve tissue. The majority of nerve tissue is protected from antibody because it's within the brain and the central nervous system, and the antibody can't get in there. But some of the peripheral nerves, particularly pain fibres, are exposed to the antibody, and that explains some of the side effects. And there's been 3 main anti-GD2 antibodies that have been used clinically, which are similar but are very different, are regarded as different clinical agents, and have been widely used now throughout the world. So the seminal study that changed our practice with the use of anti-GD2 in children with neuroblastoma was published 7 years ago from LSU's group in the Children Oncology Group in the United States, whereby an anti-GD2 antibody was given with 2 cytokines, interleukin-2 and GM-CSF, with the aim of boosting the patient's immune system, the natural killer cells in the patient, to better gobble up tumour cells coated with antibody. And what that study found when they published their results was that children who'd had this antibody in combination with the interleukin-2 and the GM-CSF, at 2 years after they'd started the antibody treatment, there was a roughly 20% improvement in the number of children who were free from relapse and were well. And that was a major kind of change in the outcome compared to what we'd seen previously, and so really kind of changed worldwide practice. And within less than a year of that study being published, antibody had been introduced within Europe and was given to virtually all children within the UK with high-risk neuroblastoma since that point. However, although this was a major breakthrough, there were some limitations to this new therapy. Firstly, when you give the antibody, you get significant pain because it binds to the pain fibres that are exposed to antibody, and there can also be allergic reactions and leakage of fluid in the wrong bits of the body when you give it. So in general, in the first study that was published, children were in hospital on morphine infusions and really quite unwell while they received the antibody. And more importantly, as time went on, it became clear as the longer follow-ups data from the LSU study became clear, the lines between the different groups closed as time went by, showing that in some children, rather than actually curing the neuroblastoma, we were just delaying relapse. And so, though it was an improvement, there was still certainly significant room for further improvement of this treatment. The other thing that was not clear from the study, because all children had had the interleukin-2 and the GM-CSF, is whether those cytokines were really needed for the efficacy and the effect of the anti-GD2, or whether they just actually made the side effects and the toxicity worse. So as a result of that study, there were two studies that happened in Europe. For one, the Southampton Highrisk neuroblastoma study, and the other, the Southampton Longterm infusion study, both looking to improve the efficacy and so how well the antibody worked, but also how tolerable it was for children. So you've seen this earlier. This shows the treatment that children with high-risk neuroblastoma have within Europe and indeed largely across the world, that they have a period of induction chemotherapy, surgery, then high-dose chemotherapy, radiotherapy, and then antibody at the end. And what the European Southampton Highrisk study did was to look and see whether the IL-2 was really of any benefit in conjunction with the antibody. And the initial results from that study showed that actually there appeared to be relatively little difference in the outcome of these children in terms of relapse. And you see the red line is children who've just had antibody, and the blue line is children who've had interleukin-2 as well. And there really were very similar lines with no clear difference between them. But what was clear was that the children who'd had the interleukin-2 injections had far more side effects and toxicity, were far iller while they had the antibody. And importantly, that meant that a large proportion of these children didn't actually complete the total amount of antibody that they were due to get. The antibody infusions had to be stopped because of the side effects. The other important thing from this was that the outcome from these graphs actually were very comparable to that seen in the American study, an LSU study. If you look slightly more carefully at those numbers and tried to pull out those patients who'd managed to complete all that antibody therapy, then it did seem that there may possibly be some benefit of having the interleukin-2 with it. So the blue line separates slightly from the red line. That's not really justified to do because you've kind of cherry-picked the best responders afterwards and those who've tolerated the antibody. But it does suggest that if you were able to find a better way of delivering the antibody so that the side effects were more tolerable, then maybe you could then benefit from the effects of giving interleukin-2 with it. Which led to the second study that I mentioned, which is called the Longterm infusion study. And what that study looked at was if you slowed down the infusion of the antibody, so rather than give it as 8-hour infusions 5 days in a row, it was given as a continuous infusion over 10 days, so over 240 hours. Would the side effects be more tolerable? Would more children be able to receive all the antibody? In order to do that, it was given through these pumps, which don't have any batteries or electric supply. It just slowly releases the antibody at 2 mL an hour over the 10-day period. It means that children can potentially go home if they're well. And what this study found was that fewer children needed morphine infusions. Many children could manage without IV morphine or even some without oral morphine. And it enabled some children to be treated as outpatients rather than in hospital. It actually achieved better levels of antibody in the blood, which is potentially better for treating the neuroblastoma. And so what the study went on to do is, in these children having the antibody in a more tolerable way, is to look again at whether the IL-2 was of benefit. And that study closed to recruitment at the end of last year, and half the patients have had IL-2 and half haven't, and we await the results of that. But in the meantime, giving the antibodies a slow 10-day infusion has become our standard of how we would give the antibody, because we know that it's definitely more tolerable. And on the basis of that, the Highrisk study, the upfront study for newly diagnosed patients, is looking again at whether the interleukin-2 is a benefit if you can deliver the antibody slowly in a more tolerable way, and also using a slightly lower dose of antibody. So that type of antibody, anti-GD2, is directly targeting the tumour cells. The antibody binds the tumour cell, highlights it to the immune system, and the immune system then comes in. One of the limitations of that is that once the antibody's gone out the system, which it will do after a week or so, is that the body isn't left with any immunity. That it's not the body's own immune response. You're giving passive immunity to the patient while the antibody lasts in their system. And it's great if it clears all the tumour cells that are there and they're gone, but it won't give the patient any long-lasting immunity. So that, as with chickenpox, and you have long-lasting immunity, so if you meet chickenpox 10 years later, your immune system still can react. Giving anti-GD2 antibody, we don't think does that very effectively. So potentially a neater way of doing it may be to actually use the body's own immune system to fight the tumour, in order that you can leave the patient with long-term immunity to the cancer. And so PD-1 antibodies actually are using antibodies to, rather than to target the tumour, you're targeting the immune system. So it relies on the fact that the immune system recognises tumour, it knows it's foreign, and even in neuroblastoma, we know that children make some sort of immune response to it. But on the whole, because it's not that dissimilar from normal cells of the body, it's not as foreign to the body as a virus or a bacteria, the immune response that the body makes is weak and is ineffectual, and by definition it's not controlling the tumour, otherwise they wouldn't have presented with symptoms. And part of the reason for that is that the tumour is not as foreign to the body as bacteria, viruses, but also the immune environment is not as inflammatory. There's not as many signals telling the immune system that it needs to make an immune response. The immune response to anything is tightly controlled so that we don't overreact or underreact to anything that we meet. So we're constantly inhaling or eating or touching things that are foreign to us. And what we don't want to do is to make an immune response to everything in the environment or in our guts or our normal tissues of the body. So we've got a whole load of control switches within the immune system that carefully control that we react enough if we've got something dangerous, so an infection, but we don't react if we just inhale something that's a bit foreign to us. And so when the immune system meets a tumour, the volume switch on the immune response that we make is turned down very low, and we don't make a very big immune response. What has come to light over the last decade really is that just as we use antibodies to target the tumour cell itself to eradicate the tumour, we can actually use antibodies to bind to the immune system and to switch on those volume switches and turn up the amplitude and the volume of the immune response that we make. And that's using the antibodies to kind of flick the on switches to the immune system to make a better immune response. And what the aim is with that is to just turn up the volume on the body's own immune response to tumour so that whatever was there naturally is more enhanced and stronger and better able to fight the tumour. The advantage of that is because the antibodies target the immune system, everybody's immune system is the same, and you don't need to have different antibodies for different tumours. It's a potentially off-the-shelf antibody that just turns up the volume on your immune system. And it potentially gives you a long-lasting immune response that gives you immunity to your tumour that lasts beyond the actual duration of the antibody itself. This type of antibodies, so antibodies that target the immune system rather than the tumour, are actually changing the way that adult cancers are being treated. And for many different adult cancers now, firstly melanoma, but since then lung cancer, kidney cancer, head and neck cancers, this type of antibody has been licensed and is being used as first-line treatments. And you can see on the right here a kind of fairly dramatic example of this, of a nasty melanoma on the face of a patient, and they're given some of this antibody that targets the immune system. And 3 months later, the tumour's regressed, but also a biopsy from there. All the black dots in the biopsy show cells of the immune system that have flooded into the tumour to eradicate the tumour. And there's this. So for many adult cancers now, these have been used as part of the upfront treatment, and I think there's now over 500 different trials of just one of these antibodies, anti-PD-1, in progress. The first trials of these type of antibodies in children have now completed. So the trials that have shown that they're generally the side effects, the doses are very similar to in adults, but we don't know yet whether they'll work in children. What's been gleaned from all the adult studies so far is that they generally work best when they're used in combination with other things. So whether it's other immunotherapies, chemotherapy, radiotherapy, whatever you put them with, it seems to enhance the effect. There is some scepticism about whether this type of antibody will work as well in children's cancers as it will in adult cancers. One of the things about melanoma and lung cancer is they're very mutated tumours. They're very foreign to the immune system because they're caused by carcinogens or ultraviolet light that have caused lots of DNA damage to the tumour. These tumours are quite foreign, whereas paediatric tumours, they don't have as many mutations in them. They're relatively unforeign to the immune system, and therefore the body's own immune response to the children is not perhaps as strong as it would be for melanoma or lung cancer or other types of adult tumours. And this graph here on the right shows the number of mutations within different types of tumour. And on the right-hand side is melanoma, lung cancer and adult tumours. And neuroblastoma comes right over to this side, showing that it's much less mutated. Nevertheless, there's some adult tumours such as breast cancer, which are similar level of mutation to neuroblastoma, where there has been effectiveness reported of this type of antibody. Other potential challenges of using this type of tumour in children is that children's tumours generally grow much quicker than adult tumours, and this type of therapy can take a relatively long time to work. So it may take 2 or 3 months before you see response in a melanoma, whereas lots of paediatric tumours can grow quite quickly over that time. So we may need to use them in conjunction with other things in order that the tumour is controlled while the immune response is developing. The other challenge we have is many of our patients have had very intensive chemotherapy prior to having this sort of therapy, and so the effect that we may have had on the immune system may inhibit this sort of antibody working. Nevertheless, so we lost a picture there. In work we've done in Southampton, we found that these molecules, this type of antibody targets are found in neuroblastoma, and we can find cells of the immune system expressing the PD-1 molecule in neuroblastoma tumours. In mouse models, so in preclinical models, we can see that these type of antibodies can have an effect, and these graphs show the tumours growing when they're given a control antibody, but established tumours will start to regress and go away and stay away when they're given this type of antibody therapy. From adult studies and lots of preclinical studies, we know that this type of antibody works well with other treatments, whether it be chemotherapy, other immunotherapies, radiotherapy, and work by Holger Loder, who's coming later and is speaking tomorrow, has shown that actually these type of antibodies seem to enhance the effect of anti-GD2 antibody. So this is mouse work showing these mice here are mice that are not given any treatment. These 2 pale lines here are mice that are given either the anti-GD2 antibody or the anti-PD-1 antibody, and this top line here is mice that are given both the antibodies together, so it seems to enhance the number of mice that survive. And what Holger has shown is that the anti-PD-1 antibodies, the antibody targeting the immune system, seems to actually enhance the ability of the immune system to clear neuroblastoma cells that are coated with anti-GD2, but also in reverse, the dying tumour cells that are dying from the anti-GD2 therapy probably enhance the effects of the anti-PD-1 therapy. So it's a two-way interaction that each is enhancing the effect of the other. And that's some of the work that has formed the basis of the MiNivAn study, which we hope is opening soon. So this is a phase 1 study, so it's testing whether this combination of drugs is tolerable and what the side effects are of the 2 antibodies, so anti-PD-1, so nivolumab, and anti-GD2, or CH1418, and given together with MIBG therapy. And this is a collaborative study with a team from myself in Southampton, Mark Gaze, who's based at UCLH in London, Paul Sondel, who is based at Madison in Wisconsin, and Holger Loder in Greifswald in Germany. And it was funded by the Solving Kids Cancer Embrace Initiative with support from Jack as well. And the rationale for the study is that these 2 types of antibodies, so antibodies directly targeting the tumour and antibodies that target the immune system, will synergise or work well together to mutually enhance each other's effects. But that also there will be a beneficial effect by having MIBG therapy in as well. So MIBG therapy, people may have heard of. MIBG is a chemical that is taken up by neuroblastoma cells, and it can be used therapeutically if a radioactive iodine molecule is linked onto the MIBG so that the radiotherapy is delivered directly to the neuroblastoma. And that's a way of delivering the kind of neuroblastoma delivering radiotherapy to all the different bits of the body. And work that Paul Sondel has done in Madison has shown that radiotherapy potentially enhances the effect of the anti-PD-1 type antibody, but partly by killing the tumour cells, you provide dead tumour cells, which fuels the immune response. It almost has a vaccine effect. But also the radiotherapy may have a positive effect on the immune system in that it gets rid of some inhibitory or regulatory T cells within the tumour. So the idea is that the three of these together will all individually contribute to producing a long-lasting immune effect, so the children are left with long-term immunity. So the synergy between these three mechanisms. So the treatment will be to start with MIBG treatment. So children will get 2 lots of MIBG therapy 2 weeks apart, and in the UK that will be at UCLH in London, given by Mark Gaze. And then 2 weeks after that, children will start anti-PD-1 therapy, so nivolumab, which is given every 2 weeks as a short infusion over half an hour. And then in conjunction with that, children will get anti-GD2 antibody given as a 10-day infusion as per the long-term infusion study. So the 2 antibodies will run in parallel to each other. The dose of MIBG therapy is relatively low so that children won't need a stem cell rescue after it that is sometimes needed, and that the dose of anti-PD-1 will be a standard adult dose, obviously adjusted for weight, but the standard dose. Because these 3 agents have never been used together, the first patients that we give this to would just get 2 of the therapies, so they'll get the MIBG therapy together with the anti-PD-1 to check that there's no unexpected side effects and that it's tolerated. If those first 3 or 6 patients tolerate that therapy with nothing unexpected, then we'll then introduce the anti-GD2 therapy, and we'll give that at a reduced dose compared to the normal dose that's been established. And if those patients tolerate the 3 agents with a reduced dose of anti-GD2, we'll give all 3 together with a full dose of each agent, and we'll treat about 18 patients with that, so we get some idea of not just whether it's tolerable, but whether it's doing anything beneficial in those patients. And in those patients, we'll not only be able to measure the tumour and see whether there's tumour responses, but also we'll look carefully at the patients' and children's immune systems and see what sort of immune effect we're having. This type of study, because it's a phase 1 study, it's the first time these combination of agents have been used together. We will be offering to children with relapsed or refractory disease for which there aren't any other established treatments that we think are going to be curative. Children have to have MIBG disease on scans, because otherwise there'd be no point giving the MIBG element of the treatment. It doesn't matter whether they've had anti-GD2 before, as long as they've not had any serious allergic reactions to it or not tolerated it for any reason. And they can have had MIBG therapy before. We've deliberately not put an upper age limit on the study because there are rare cases of much older patients who have neuroblastoma, which we'd like to include if possible. And as with all studies, patients have to have adequate kidney, liver, heart, lung function to be eligible for the study. In the UK, the MIBG therapy will be given in London, and the antibody therapy will be given in Southampton, and Mark Gaze in London and myself will work very closely to see any potentially interested patients who it might be suitable for, and to coordinate how we work this. And it will work in very close collaboration with Paul Sondel in Madison and Holger Loder in Germany. And so since we first were awarded the funding for this study almost 2 years ago, we've had telephone conferences with Madison and Greifswald every 2 weeks to discuss what progress we're making and overcome all the kind of obstacles we've had to opening this international study. This will be the first ever transatlantic neuroblastoma study, and so there's been a number of regulatory hurdles to overcome to make sure that happens. And one of the exciting things about it has actually been having regular contact with Paul and Holger to overcome those and to make progress. We hope we're now at the point when we're almost open in the UK. We have regulatory approval to open in the UK, and we're just at the stage of the final contracts and approvals from the individual hospitals. But we hope we're within weeks rather than months of opening. One of the other exciting things about the study has been that the motivation and initiative for the trial came from Solving Kids Cancer, with funding from other partners as well, including Jack. But that, with the confidence that showed in the scientific design of the trial, we were then fortunate enough to secure not just antibody supply from two major pharmaceutical companies, Bristol Myers Squibb and EU Pharma, but also financial support from them that has helped with the international monitoring and international oversight of quite a complex study. So the study now has multiple partners, in that it's got 2 different drug companies, multiple charities, several international institutions in different continents, and it has been quite a feat of coordination to get to this point. Before I finish, I just want to briefly mention the Beacon study, because it again is going to hopefully incorporate anti-GD2 in combination with other things. So people may have heard of the Beacon study. It's a randomised study which is looking at what the best treatment is for relapsed neuroblastoma, what the best chemotherapy treatment is for relapsed neuroblastoma, that has been open across Europe, and the UK has recruited a sizable number of patients, and it's had 6 arms comparing different chemotherapy options, but also bevacizumab, which is a type of antibody which affects the blood supply to tumours. And what we are hoping to do is, when the study has completed recruitment of the number of patients it needs to assess the effect of bevacizumab, we hope that we can substitute that with anti-GD2 to look at the benefit of combining anti-GD2 antibody with the chemotherapy arms. And that's come from very exciting work that's come over the last year, 18 months from the States, and 2 trials which you're going to hear about later today, which show that potentially giving anti-GD2 in combination with chemotherapy looks as though it may be a very powerful way of treating neuroblastoma. And so we're hoping that we can incorporate this into the Beacon study in order that we can get this open relatively quickly within the UK and Europe. So I think I'll finish there, and I just wanted to summarise by saying, in terms of the MiNivAn study, it's combining anti-GD2, which we know has survival advantage in high-risk neuroblastoma, but sadly, despite the improvements with it, a large proportion of children will still relapse. There's lots of room for improvement. And combining with anti-PD-1, which has become a very widely used therapy in adult cancers, but is relatively unexplored in paediatric cancers. And we hope those 2 together, combined with MIBG therapy, will be a powerful way of generating an immune response against tumour, which will give patients long-term immunity to the tumour. And we hope it will be opening very soon in the UK. And I can't put a date on that until we've got the last box ticked. We don't know exactly how long it will be, but we are very close, and I hope it will be either this side of Christmas or early in the new year. And secondly, just to say that the particularly data from the States shows that using anti-GD2 with chemotherapy looks very exciting, and amendments to the Beacon study we hope will be able to be introduced to test this within the UK. And again, I can't put a timescale on that, but we hope that that can be done relatively soon.